Chapter 15, Diseases of the Lower Gastrointestinal Tract. Learning objectives. Explain the normal anatomy and physiology of the lower gastrointestinal tract. Summarize the nutrition assessment for lower gastrointestinal tract conditions. Discuss underlying conditions of diarrhea, constipation, and malabsorption. Complications associated with each and appropriate nutrition therapy. Explain the pathophysiology, medical care, nutritional implications, medical nutrition therapy, and specialized nutrition support used for celiac disease, inflammatory bowel disease, irritable bowel disease, short bowel syndrome, and small intestinal bacterial overgrowth. Describe the surgical procedures used in the lower gastrointestinal disease states, the nutritional consequences, and the appropriate nutritional care. An exploration of pathophysiology affecting the small and large intestine quickly reveals that nutrition therapy is the foundation of treatment for many of these diagnoses. For some of these, such as celiac disease, nutrition therapy is the only treatment. The small intestine is composed of three distinct parts: the duodenum, jejunum, and ileum, and averages approximately 16 feet in length. These are not separate compartments, but differ in anatomy, motility, secretion, digestion, and absorption. The ileocecal valve is the sphincter muscle that separates the small intestine and the large intestine. The anatomy of the small intestine is both unique and highly functional. This anatomy is organized to provide maximum surface area and allow for complete digestion and absorption of most foodstuff. First, the tissue of the small intestine is circularly folded into what are referred to as folds of Kinkering risings from the mucosa surface or finger-like projections called villi. On the surface of the villi are fine hair-like projections called microvilli. This surface is often referred to as the brush border. This combined features of these anatomical structures increase the surface area of the small intestine to such an extent that is 600 times greater than it would be if the intestine were straight, flat, or a tube. Figure 15.1, sphincter of the gastrointestinal tract. The small intestine contains gut-associated lymphoid tissue that interact with foreign antigens to initiate an immune response. The health and function of the GI tract are strongly influenced by the nutritional status and or disease. More than 50% of the small intestine has to be removed before any significant reduction in its capability is observed. The duodenum and the jejunum can perform each other's roles in both digestion and absorption. The ileum can also adapt into this way up to a certain point. The ileocecal sphincter protects the small intestine from bacteria translocation from the large intestines by remaining closed except during the digestion process. Motility of the small intestine is regulated by a number of neural and humoral factors, including hormones, peptides, and neurotransmitters, many of which are impacted by dietary composition. As chyme enters the duodenum from the stomach, the hormone gastrin and the intestinal pacemaker cells stimulate the onset of segmental contractions. This segmentation motility allows mixing of chyme with digestive secretion. In the duodenum, contractions occur approximately every 9 minutes with a slower rate further down the small intestine. It may take as long as 3 to 5 hours to complete the process. When the small intestine is empty, motility continues with the action of the migrating motility complex, or MMC. MMC consists of much weaker contractions that occur approximately every 100 to 150 minutes and serve the purpose of ridding the small intestines of any leftover bacteria waste or waste. The anatomy of the small intestine also influences motility and the rate of transit. The ileocecal valve helps to control the rate of movement of food from the ileum to the ascending colon. The small intestine produces its own secretion and also receives secretions from ancillary organs of digestion, including the pancreas and gallbladder. These secretions include hormones, digestive enzymes, bicarbonate, and bile. As chyme moves from the stomach into the duodenum, the hormones cholecystokinin, gastrin, and secretion stimulates release of pancreatic and gallbladder secretion. Bicarbonate from the pancreas neutralizes the very acidic chyme as it enters from the stomach. Bile from the gallbladder supplies emulsification from adequate lipid digestion. Figure 15.2 is segmentation. Please review. Figure 15.3 shows the ileocecal valve. Pancreatic juices provide the primary digestive enzymes in the small intestine. Pancreatic amylase is the primary enzyme involved in starch digestion. Pancreatic lipase and colipase accomplish the largest portion of the lipid digestion. Figure 15.4, carbohydrate digestion and absorption. Please review. Number one, the dietary polysaccharides, starch, and glycogen are converted into the disaccharide maltose through the action of salivary and pancreatic amylase. Please review this flow. This is figure 15.4, carbohydrate digestion and absorption continued. Figure 15.5 discuss the protein digestion and absorption. It's continued on the next slide. Figure 15.6 discusses the lipid digestion and absorption. Also, please review. The anatomy of the small intestine is uniquely constructed to accomplish maximum digestion and absorption. Absorption from end products of digestion occurs primarily through active transport and may utilize sodium and potassium pump system at the brush border. Glucose, galactose, and amino acids utilize this type of absorption mechanism. Fructose uses facilitated carrier mediated transport as its absorptive mechanism and is affected by the presence of glucose, amino acids, and the total amount of fructose. Fructose malabsorption has been of recent interest for the potential contribution to gastrointestinal symptoms. Some research indicate that some nutrients, including glucose, may be absorbed in part through a periocellular route. This means that the small amount of nutrients may leak between epithelial cells. I say again, this means that small amounts of nutrients may leak between epithelial cells. Lipid absorption is much more difficult due to its insolubility in water. For lipids to be successfully absorbed, they must undergo several steps and utilize several protein carriers. Fatty acids and other lipid components must be first incorporated into the micelles of the gut lumen before the absorption into the erythrocytes. Then they must be incorporated into the chylomicrons that can then enter the lymphatic system. Understanding the steps of Digestion absorption can assist in variations of diseases affecting small intestines and or ancillary organs of digestion. Examples: pancreatic disease may reduce the amount of pancreatic lipase available for adequate digestion. Crohn's disease may decrease transient time and reduce the ability required for digestion and absorption. Steatorrhea, an abnormal amount of fat in the stool, is the condition that develops when lipids are not digested or absorbed correctly. Portions of the small intestine can adapt to absorb most nutrients. However, in a normal, healthy individual, most nutrients will be absorbed in the duodenum or jejunum. The ileum can also accommodate absorption of many nutrients if foodstuff remains there long enough. One exception to this is the absorption of B12, which can occur only at specific receptor sites in the ileum. The ileum is also a primary site for reabsorption of bile acids. Figure 15.7 discuss sites of nutrient absorption. Please review. The anatomy of the large intestine has both significant difference from and important similarities to the anatomy of the small intestine. First, mucosa of the large intestine is from three nearly straight portions rather than circular folds found in the small intestine. The colon's major portion are referred to as ascending colon, transverse colon, and the descending colon. The final section of the colon is referred to as the sigmoid colon due to the S shape. The sigmoid colon ends in the rectum, where another sphincter controls voluntary release of intestinal contents. The large intestine does not have villi or microvilli, though it contains large pits or cripes that are similar to the cripes between the villi and the small intestine. Figure 15.8, this shows the large intestine's anatomy. The musculature of the large intestine provides the basic structure that supports its motility. The large intestine has repeating bands of longitudinal skeletal muscle that follow the length of the colon and circular smooth muscle that covers the entire organ. Motility of the large intestine can be categorized into several distinct types. The large intestine also uses a type of segmentation called holustration. Holustration occurs when circular muscle forms small sacs called halustra. Proportion is accomplished by alternating waves of relaxation and contractions of smooth muscle lasting several minutes. Mass movement occurs when there is a significant contraction of a large portion of the colon. This generally occurs several times a day and moves a large portion of intestinal contents along the colon. Defecation occurs when distension of the rectum relaxes the anal sphincter. This final movement is ultimately under voluntary control. Goblet cells produce mucus that serves to protect the epithelium and assist in formation of feces. Potassium and bicarbonate are both released in the large intestine, and they play a role in the electrolyte and fluid absorption that occurs there. No enzymatic digestion occurs in the large intestine. In normal, healthy individuals, digestion has already been accomplished by the time chyme exits the small intestine. The primary function of the large intestine is to provide a site for reabsorption of water, electrolytes, and some vitamins. The colon's role in absorption is even more important when disease affects the small intestine. The colon can increase its absorption significantly, as much as 3 to 5 times more than normal in a setting of a small intestine disease. The second major function of the large intestine is to serve as a site for formation and storage of feces. When chyme enters the large intestines from the ileum, it is primarily liquid. As the chyme moves along the colon, water is reabsorbed, resulting in a drier mass of fecal matter. Feces contain undigested foodstuff, primarily insoluble fiber, bilirubin, and bacteria. Colonic transit is sluggish compared to the rest of the intestine and may take anywhere from 12 to 72 hours. As many as 1,500 different species of bacteria. These species provide fermentation of fiber, resistant starch, sugar alcohols, and some polyphenols. As substrates undergo fermentation, short-chain fatty acids and lactase are produced. As substrates undergo fermentation, short-chain fatty acid and lactic are produced. Some of the energy produced during fermentation is used directly by bacteria for their own support. As short-chain fatty acids, they release 15 to 1,220 kilocalories per day for human hosts. When there is excessive substrate in the colon, such as undigested carbohydrate, gas and flagellants may result. Many factors affect not only the amount, but also the type of bacteria in the colon. These factors include age and health status, composition of the diet, stress, geography, medication use, birthing methods, and infant feeding practice. Maintaining an optimal balance of intestinal flora is a significant interest in human health and nutrition. The use of resistant starch, prebiotics, probiotics, and symbiotics is currently being studied in an effort to determine their role in colonic and microbiota health and in prevention and treatment of disease. Nutrition assessments involve gathering the appropriate data in order to identify nutrition problems and establish nutritional status. Nutritional assessment for the lower gastrointestinal tract. You want to make sure that you get the client's history, personal, the patient, the family, the medical, and the social, previous medical conditions or surgeries, medication, both prescription and over the counter, social economic status, food security, support system, education, and finding out their primary language. So the nutrition assessment, you could do food nutrition related history, ability to chew, use and fit of dentures, problem swallowing, nausea, vomiting, constipation or diarrhea, relationship of food ingestion to GI symptoms or signs or symptoms, and any symptoms interfering with ability to ingest, normal diet, ability to consistently purchase adequate amounts of food on a daily basis, ability to feed, self, cook, and prepare meals, food allergies, preferences, and intolerances, previous food restrictions, ethnic, cultural, and religious influences. Discontinuing use of alcohol and vitamin, mineral, herbal, fiber, or other types of supplements, previous nutrition education or medical nutrition therapy, eating pattern, 24-hour recall, diet history, and food frequency, anthropometric measurements, height, the current weight, weight loss history, so the highest adult weight, usual body weight, and a reference rate using the BMI. Just continuing, you can do look at the nutrition focus and physical exam, look at the skin, nails, head, neck, or hair, subcutaneous fat, muscle mass, abdominal exam, vital signs, edema. The biochemical data or medical tests and procedures, you can look at the visceral protein assessment, inflammation assessment, hematological assessment, lipid assessment, lower GI specific biochemical data, medical tests and procedures, folate, looking at different vitamins, vitamin C, D, B12, B6, K, A, and E, biotin, niacin, riboflavin, thiamine. Diarrhea is defined as an increase in frequency of bowel movements and an increase in water content of stool that whether the consistency affects the consistency or the volume of fecal output. Annual incidence of infectious diarrhea in the United States is estimated to be approximately 99 million new cases, resulting in 3,100 deaths. This is the sixth leading cause of infant deaths in 2005. Foodborne illnesses are a major cause of these cases. The World Health Organization describes diarrhea as the second leading cause of death worldwide, and each year, 525,000 children under 5 will die from the consequences of diarrheal diseases. Prevention and treatment of diarrheal diseases is a primary focus of public health intervention throughout the world. Diarrhea can be described as either acute, persistent, or chronic in origin. It can also be classified as either osmotic or secretory. Acute diarrhea is short term, less than 2 weeks. Persistent diarrhea lasts 2 to 4 weeks. And diarrhea that lasts longer than 4 weeks is considered chronic. Diarrhea can be associated with a number of health conditions such as electrolyte imbalances, malabsorption, dehydration, and malnutrition. Osmotic diarrhea can be caused by maldigestion of nutrients, excessive sorbitol or fructose intake, enteral feeding, and some laxatives. In general, when the causative agent is removed, osmotic diarrhea is ceased. Secretory diarrhea also results from excessive fluid and electrolyte secretion into the intestines. Medication generally cause diarrhea by increasing GI motility or by altering the normal flora of the colon. Enteral feedings are often implicated as a cause of diarrhea. I'm going to say that again. Enteral feedings are often implicated as a cause of diarrhea. Please remember that when you are working with patients who are on some type of enteral feeding. Even though changing types of formulas or reducing rates of feeding is often proposed, the evidence for the effectiveness of this strategy is very limited. Other conditions that might present as diarrhea include pseudo-diarrhea, fecal incontinence, and overflow diarrhea. The medical provider will rule out these conditions as etiology of diarrhea is being examined. Table 15.3, these are medications that can cause diarrhea and potential etiology, so please review. This is the table continued. Diarrhea presents as a change from the normal bowel function. This is generally a watery stool that is increased in frequency. Other characteristics of stool output will vary depending on the etiology of the diarrhea, such as foul smelling. Frothy stool is associated with steatorrhea. Additional clinical manifestations that may occur with diarrhea are abdominal pain and cramping. Diagnosis of underlying etiology is the most important step in determining treatment of diarrhea. Considerations that will direct diagnostic procedures are the age of the patient, hydration status, the presence of blood in the stool, or whether the patient is immunocompromised. Important symptoms to note are any recurring characteristics of diarrhea episodes, including time of day or any relationship to food intake. Typical diagnostic workups will begin with blood samples to rule out inflammatory processes such as celiac disease and inflammatory bowel disease. Next, stool cultures will be examined for microorganisms, parasites, leukocytes, and presence of blood. Further invasive procedures such as the upper endoscope or colonoscopy may assist in diagnosing not determined with initial blood work or stool cultures. Osmolarity and electrolyte content of the stool can also be determined and will assist in distinguishing between osmotic or secretory diarrhea, but these measures are used less often in clinical practice. Nutritional consequences of diarrhea are initially dependent on the volume of gastrointestinal losses and then on the length of the disease course. Large volume losses can quickly lead to dehydration and electrolyte acid balance imbalances. Hyponatremia, hypokalemia are both common in diarrhea. Metabolic acidosis may develop due to the excessive loss of bicarbonate ions in stool output. Infants and older adults are at a particular higher risk because their bodies are much more sensitive to rapid shifts in both fluid and electrolytes. Chronic diarrhea can also cause fluid and electrolyte complications and can result in malnutrition and specific nutrient deficiencies. When completing a nutrition assessment for a patient with diarrhea, it is especially important to review the following types of assessments: fluid and beverage intake, energy and mineral intake, medication and herbal supplement use, safe food and water availability, weight change, biochemical data, nutrition focused physical findings, past medical and surgical history. Common nutrition diagnoses associated with diarrhea and its physical impact on nutritional status include inadequate energy intake, inadequate oral intake, inadequate fluid intake, altered GI function, and involuntary weight loss. Nutrition therapy for diarrhea is designed to restore normal fluid, electrolyte and acid-base balance, decrease gastrointestinal motility, thicken the consistency of the stool. Historically, nutrition therapy for diarrhea has included making the patient NPO or clear liquids. Current practices recognize the importance of stimulating the GI tract, may use oral rehydration solutions, focus on decreasing motility, use of prebiotics and probiotics. Table 15.7 is the World Health Organization reduced osmolarity oral rehydration solutions. This is the chart continued. Nutrition therapy for diarrhea, milk and milk products. If you have lactose intolerance, drinking milk products may aggravate the diarrhea. So you want to try lactose-free products. Avoid yogurts with nuts and or dried fruit. Protein, small protein of high fat foods without skin or casings can be tolerated in short bowel syndrome. Your grains, you want to choose grain foods with less than 2 grams of dietary fiber per serving. Fruit, canned, unsweetened soft fruit, ripe bananas. Vegetables must be well cooked without seeds or skin. You want to limit fats to less than 8 teaspoons per day. Drink more to replace fluids lost to diarrhea. Rehydration beverages may need to be considered. Limit foods and beverages that contain excessive sugar, lactose, fructose, high corn syrup, fructose. Avoid and minimize beverages with caffeine. Eat small meals or snacks every 3 to 4 hours. If any food makes diarrhea worse, stop eating that food. You can try it again with a diarrhea stop. Avoid spicy foods if it makes your diarrhea worse. There are many subjective definitions for constipation. Individuals describe constipation as a decrease in frequency of bowel movements, presence of hard stool, or straining to have a bowel movement, but it's difficult to interpret an individual's complaint of gastrointestinal distress. The Rome 4 consensus criteria defines constipation as a condition where at least 2 of the following symptoms have occurred for the last 3 months, with the symptoms onset 6 months prior to the diagnosis. These include straining during at least 25% of defecations, lumpy or hard stools in at least 25 of the defecations, sensation of incomplete evacuations for at least 25% of defecations, sensation of obstruction, blockage for at least 25% of defecations, manual maneuver of a facility of at least 25% of your defecations, fewer than 3 defecations per week. Loose stools are rarely present without the use of laxatives. There are insufficient criteria for diagnosing irritable bowel syndrome. Constipation can result from several different distinct causes and can be characterized as idiopathic or secondary. Slow transient constipation is characterized as idiopathic constipation and results from lack of propulsion through the colon. Pelvic floor dysfunction can cause not only slow colonic transit, but also storage of fecal content in the rectum for long periods of time. Constipation can be a major component of irritable bowel syndrome. Constipation can be a side effect of many different medications. Symptoms of constipation include decreased frequency of bowel movement. Bowel movements are often hard and pellet-like. Abdominal pain, bloating, and gas are common accompanying symptoms. Treatment of the underlying etiology will direct medical care for constipation. Nutrition therapy for constipation. Nutrition assessment data should include your fluid and beverage intake, dietary fiber intake, bioactive substance intake, beliefs and attitude, misuse of medication, especially laxatives. Nutrition diagnosis may include inadequate food or fiber intake, altered GI function, or undesirable food choices. Recommendations include increasing whole grain fruits and vegetables, 25 to 38 grams of fiber intake per day, increasing fluids to about 2,000 milliliters per day, and incorporating probiotics and prebiotics daily. Tips for adding fiber to your eating plan: slowly increase the amount of fiber you eat to 25 to 38 grams per day. Eat whole grain breads and cereals. Look for choices with 100% whole wheat, rye, oats, or bran as the first or second ingredient. Have brown or wild rice instead of white rice or potatoes. Enjoy a variety of grains. Bake with whole wheat flour. Add dry beans and peas to casseroles or soups. Choose fresh fruits and vegetables instead of juices. Eat fruits and vegetables with peels or skins on. Compare food labels of similar foods to find higher fiber choices. Check the nutrition facts labels and try to choose products with at least 4 grams of dietary fiber per serving, nothing less than 2 grams per serving. Drink plenty of fluids. Set a goal of at least 8 cups per day. Fluids help your body process fiber without discomfort. Malabsorption is a general term referring to malabsorption of fat, carbohydrates, or protein as a result of maldigestion or damage to the anatomy and physiology of the small intestine. Damage to the anatomy and physiology of the small intestine due to disease is the most common cause of malabsorption. Dysfunction of an accessory organ of digestion, including the liver, pancreas, and gallbladder, may also serve as an origin of the maldigestion. Decreased transient time, as seen in diarrhea or following surgical change in the anatomy, can also result in either maldigestion or malabsorption. Possible causes of malabsorption: inadequate digestion, reduced intraduodenum bile acid concentration, impaired micelle formation, or liver disease. Bacterial overgrowth in the small intestines, functional status, interrupted enterohepatic circulation of bile salts, impaired mucosa absorption, mucosa loss or deficit, impaired nutrient delivery to and from the intestines, endocrine and metabolic disorders. Nutrient digestion, absorption are dependent or normal anatomy, normal physiology with adequate production of enzyme, hormones, and other secretions such as bile and appropriate motility. The digestion and absorption process for lipid or fat is the most complicated and therefore the easiest to disrupt. Fat malabsorption is called steatorrhea, literally meaning the fat in stool. Digestion and absorption of fat requires adequate pancreatic lipase, adequate emulsifier bile from the liver and gallbladder, and adequate secretion through the common bile duct and pancreatic duct. When any of these processes is disrupted, fat remains in the stool and travels undigested and unabsorbed to the large intestine. Fat-soluble vitamins are malabsorbed as well. The most common example of carbohydrate malabsorption is lactose malabsorption, commonly referred to as lactose intolerant or lactose maldigestion. Bacteria in the large intestine will cause the lactose to undergo fermentation, which creates increased gas and abdominal cramping. Lactose intolerance is commonly associated with other gastrointestinal diagnoses, including irritable bowel syndrome, celiac disease, and inflammatory bowel disease. Lactose malabsorption can be diagnosed using either a lactose intolerant test or a lactose hydrogen breath test. So protein malabsorption, there's no specific disease, but it occurs as do most other malabsorption disorders as a result of other diseases. Excessive protein in the gastrointestinal tract has been noted in over 65 different diagnoses. Excessive protein is lost in the stool, and the patient will experience reduced serum levels of protein. Appropriate treatment for malabsorption of protein will depend on the nutrient that is, excuse me. Appropriate treatment for malabsorption will depend on the nutrient that is malabsorbed. So that could be protein, lipid, or carbohydrate, and the underlying disease causing the malabsorption. Nutrition therapy for malabsorption. Conditions of malabsorption can be weight change, dietary intake of macro or micro nutrients, fluid status, malnutrition, description of the stool. Nutrition diagnosis could be malnutrition, altered GI function, impaired nutrient utilization, underweight, or unintended weight loss. The purpose of nutrition therapy is to provide structure for the elimination of malabsorbed nutrients from the diet, provide appropriate substitutions in order to ensure maintenance of nutritional status. Nutrition therapy for fat malabsorption, you want to restrict the fat to 25 to 50 grams a day. Dietary interventions need to be taken. Medium chain triglycerides or MTC supplements can be used to increase the caloric intake. Restriction of all milk and dairy products, carefully monitoring the amount of lactose that can be tolerated. Products such as lactate provides the lactase enzyme. Table 15.11 is the fat restricted nutrition therapy. So this is table 15.11, the fat restricted nutrition therapy. It talks about the food group. Like, for example, if it goes over grains, it says which foods are recommended, which foods are not recommended. Please go over this. So when reviewing with patients, you know which foods are recommended and which foods are not. Continues on with dairy and fat and oils. Lactase controlled nutrition therapy recommended foods. So lactose-free milk and non-dairy products like lactose-free milk, non-dairy whipped toppings, almond, rice, or soy milk, soy yogurt, or soy cheese. Low lactose dairy products like 1 to 2 ounces of aged cheese such as Swiss cheddar or Parmesan, 2 tablespoons of cream cheese, 1/3 cup of cottage cheese or 1/2 cup of ricotta cheese. Just continuing grains, all unless prepared with ingredients that contain lactose. Low lactose dairy products, all unless they're prepared with ingredients that contain lactose. The same with fruit, fats, and oils. You want to use unsaturated oils, sulfur, liquid margarines or vegetable oil, spreads, salad dressings, nuts, and avocado. Just continuing the recommendations, desserts, you want to choose like fruit ices, sorbet, gelatin, soy, yogurt, or ice cream, rice milk ice cream, beverages, coffee, tea. You can use any spices or herbs. Lactose control nutrition therapy alternative sources for calcium, sardines, kale, dry beans, tofu, broccoli, shellfish, calcium fortified orange juice or calcium fortified soy milk, turnip greens, collards, blackstrap molasses. Celiac disease is an autoimmune disease in genetically susceptible individuals caused by immunological reactions to gluten. It is a unique autoimmune disease in that the environmental trigger is known. The environmental trigger is unknown. The genetic profile is established, and there is typically a resolution of symptoms when the triggers or the gluten is eliminated from the diet and environment. It is a unique autoimmune disease that the environmental trigger is known. Excuse me, I said unknown. Is known. The genetic profiles are established, and there is typically a resolution of symptoms when the trigger, gluten, is eliminated from the diet. Hematological studies indicate celiac is much more common than previously thought, at 1% prevalence worldwide and varies by regions. When the small intestine is exposed to specific sequence of amino acids found in the protein portion of the gluten and barley, there is a toxin inflammatory response. The immune response to the gluten signals T lymphocytes to produce various cytokines, which turns direct to the inflammatory response. Figure 15.10, small intestines villi compared to in celiac. So you see the normal small intestines villi and the small intestines villi in the celiac disease. Classic clinical symptoms of celiac disease includes diarrhea, abdominal pain, cramping, bloating, and gas, bone and joint pain, muscle cramping, fatigue, seizures, skin rash, mouth ulcerations. Traditionally, celiac is diagnosis confirmed by a biopsy of the small intestine mucosa, reversal of symptoms following a gluten-free diet. Gluten-free diet normalizes villus height and causes. So maldigestion and absorption should resolve reduction of the physical signs and symptoms. Refractory celiac disease is often due to the unknown gluten contamination in the presence of coexisting disease. So the nutrition therapy for celiac disease, nutrition assessment includes evaluation of anthropometric changes and nutrient imbalances. Nutrition diagnosis may include impaired nutrient utilization, altered GI function, and food and nutrition related knowledge deficit. Selection of an overall healthy diet with avoidance of gluten. Gluten requires a lifelong restriction. Address secondary lactase deficiency if present. So if the person is lactose intolerant, you have to address that. So lactose does not require a lifelong restriction. It's just when there's a flare up most times that the lactose has to be restricted. Just depends on the client. Figure 15.11 is gluten-free foods. Individuals with celiac disease can purchase a wide variety of gluten-free products or learn to prepare favorite dishes with alternative ingredients. Irritable bowel syndrome, or IBS. Currently, IBS is defined by abdominal pain related to defecation or a change in bowel habit that occur in association with altered bowel habits at least 1 day per week on an average preceding month. So there's 4 subtypes. You have IBS-D, which is diarrhea predominant, IBS-C, which is constipation dominant, IBS-M, which is a mix of diarrhea and constipation, and IBS-U, which is unclassified. IBS is the most common gastrointestinal complaint in the United States and Canada. The prevalence in the North America is about 12%. IBS historically has been designated as a functional disorder. This means a diagnosis is made after ruling out all possible organic causes of the patient's symptoms. Some current research is focused on multiple factors, including genetic predisposition, altered immune system response stimulated by food sensitivities, elevated inflammatory response to gastritis, small intestinal bacteria growth, abnormal release, transport, and recognition of serotonin, increased sensitivity of the extrinsic nervous system that causes abnormal motility and pain. Figure 15.12 is potential hematological factors in IBS. Please review because it talks about the communication between the body and systems, the GI tract function in an environment, and GI symptoms, and all leading to IBS, abdominal distension, and bloating. Irritable bowel syndrome pathophysiology is complex and it's not well understood. Abnormal motility plays a major role in the symptoms. There's some abnormal communication between the brain and the gut, increased sensitivity to stimulation of the gastrointestinal tract, small intestinal bacterial growth has been seen, increased permeability of mucosa. So irritable bowel syndrome clinical manifestations, you're going to see abdominal pain, alterations in the bowel habits, gas, flatulence, and a lot of upward GI syndrome. So irritable bowel syndrome's medical treatment, it's going to be guided by the symptoms. They tried different things as seen on the slide, but please review this slide to know about the treatments for irritable bowel syndrome. So medical nutritional therapy will be next. So the nutrition therapy for IBS, your nutrition assessment is specific assessment data needed to provide appropriate nutrition care, and it will vary per patient. Nutrition diagnosis may include inadequate oral intake, altered GI function, undesirable food choices, nutrition-related knowledge deficit, and a disordered eating pattern. It depends, the interventions will depend on the symptoms and the food triggers. We want to think about an exclusion diet or a FODMAP approach. You want to relieve the symptoms associated with the gas and the flatulence. Please review figure 15.13. This is proposed effects of FODMAPs on IBS symptoms. So the next few slides will talk about table 15.14, a low FODMAP diet, telling you which foods are recommended or not recommended. So please review. All right, steps to decrease gas production. You want to avoid swallowing air, avoid gas-forming foods, and eating tips, cutting back on fried and high-fat foods, eating smaller meals throughout the day, avoiding eating while anxious, upset, or on the run. Personal habits, you want to increase physical activities to a minimum of 30 minutes a day. Medications, pay attention to your medications. Talk to your doctor about your medications. Inflammatory bowel disease, interaction of both environmental and clinical factors that can cause an inappropriate immune response in genetically predisposed individuals. So figure 15.14 talks about the disease pathogenesis of IBD. So it's a comparison of colonic mucosa in normal, Crohn's disease, ulcerative colitis patients. So you could just pay attention to that as a review. So this is the inflammatory bowel disease pathophysiology. The client will experience abnormal immune response occurs in those who are genetically susceptible and exposed to certain triggers. Ulcerative colitis primarily affects the colon and the rectum. Crohn's presents with skipping patterns throughout the GI. Ulcerative colitis and Crohn's. So ulcerative colitis has ulcerations leads to toxic megacolon or a thin ulcerated colon. Crohn's disease, fistulas or replaced by fibrotic tissues. Fibrosis can cause recurrent sutures and obstructions. So some clinical manifestations can be abdominal pain, bloody stool, febrile tachycardia, elevated C-reactive protein, erythrocytes, cementation rates, elevated CAL, elevated white blood cells. So some other things could be weight loss, muscle wasting, malnutrition. This is all common with Crohn's disease and important for your when you're taking the patient information for your notes. So some treatments can be antibiotics, immunosuppressants, surgery, biological therapies, nutrition therapy for IBD. The nutrition assessment will be a comprehensive assessment is required. So the nutrition diagnosis could include malnutrition, inadequate energy and oral intake, increased nutrient needs, inadequate vitamin mineral intake, impaired nutrient utilization, food medication interaction, and altered nutrition related laboratory values. So nutrition therapy during exacerbation of the disease, enteral nutrition is preferred over parenteral nutrition. Access energy needs using standard guidelines may need to increase the protein needs. Low residue and lactose-free diet will, with small frequent meals and excess of for micronutrient deficiencies. So the nutrition therapy for rehabilitation during periods of remission, maximize energy and protein needs, ensure healthy weight gain and physical activity, normalize dietary patterns, limit foods high in oxalate, recommend probiotics and prebiotics. Diverticulosis is defined as an abnormal presence of outpockets or sacs on the surface of the small intestine or colon, most common in Western or industrialized countries. Historically associated with a low fiber diet, history of constipation or increased colonic pressure, more recently focused on increasing an inflammatory response. Other risk factors could be obesity, sedentary lifestyle, steroids, alcohol and caffeine intake, cigarette smoking. So diverticulosis and diverticulitis pathophysiology. Fecal matter is trapped and excessive pressure is exerted against the walls of the colon, leads to the development of the pouches. So diverticulitis, pouches become inflamed. Complications could be bleeding abscess, obstruction, fistula, perforation. Diverticulosis is typically asymptomatic. The symptoms of diverticulitis, fever, abdominal pain, GI bleeding, elevated white blood cells. This is diagnosed with a radiology testing. You'll see thickening walls, abscess, or inflammation. Treatments. Recent guidelines caution the use of probiotics in treatment. Patients is made NPO with complete bowel rest until the symptoms subside. Selective use in the treatment of serious infections or sepsis is recommended. Surgical resection likely occur for patients with complications. So the nutrition therapy, prolonged presence of diverticulitis with infection and inflammation impacts the patient's nutritional requirements. So the nutrition assessment will be assessment of overall nutritional status, and nutrition diagnosis includes altered GI function and inadequate fiber intake. The intervention will include a high fiber diet, restrictions of nuts, seeds, and wholes. It's not based on sufficient evidence. Fiber supplements may be used by older adults. Patients with acute diverticulitis will be progressed from bowel rest to clear liquids. Please review the common surgical interventions for nutrition. Please review the surgical interventions. Figure 15.16. These are surgical options for treatment of ulcerative colitis. The nutritional intervention goals would be decrease risk of obstruction, maintain the fluid and electrolyte balance, reduce fecal output, and minimize flatulence. After surgery, the patient is transitioned to an oral diet. Tips for nutritional therapy for ostomies: take small bites of food and chew thoroughly, eat meals and snacks at the same time each day, eat frequent small meals. Eating the largest meal in the middle of the day may decrease the stool output at night, making it easier for you to get a full night's rest. Avoid spicy or fried foods or foods high in sugar. Include sources of soluble fiber to thicken the stool. Some foods may cause odors, so you want to limit things like onions, eggs, fish, broccoli, and cabbage. Nutrition interventions decrease the risk of obstruction, maintain fluid and electrolyte balance, reduce fecal output. Oh, we just went over this. So sorry. Some foods may increase gas production. Do not drink with a straw, smoke, or chew gum or tobacco. These practices can cause you to swallow air and have gas. Have at least 8 to 10 cups of fluids per day. Food recommendations. Some people are sensitive to certain recommended foods. If these foods cause you to have gas, unpleasant odors, or diarrhea, stop eating them. After 2 to 3 weeks, you can try small amounts to see if they will cause anything. Most of the recommended foods are low in fiber. Fiber can be hard for the body to digest while you're recovering. When you start eating solid foods, it is especially important to stick to low insoluble fiber choices. As you heal, you can try foods with more fiber, such as whole grain foods. You may find it helpful to keep a list of foods that you try and write down how it makes you feel. Short bowel syndrome results from large resection of the small intestine, 2 to 3 cases per million individuals per year, extensive loss of surface area of the small intestine and the colon. So this can result in malabsorption of nutrients, fluids, and electrolytes. Please review the clinical consequences of short bowel syndrome. Short bowel syndrome's pathophysiology, the prognosis depends on the length of remaining small bowel, presence of the ileocecal valve, health of the remaining GI, and any comorbidities that the patient may have. Some symptoms can include major vitamin and mineral losses, fat malabsorption affecting vitamin A, D, E, and K, sodium, magnesium, iron, zinc, selenium, and calcium losses. So after surgery, acute phase, it could last up to 3 weeks. Extensive fluid and electrolyte losses within large volumes of the diarrhea related to hypersecretion. Adaptation phase may be extended beyond 2 years. Reduction of diarrhea volumes from changes of motility and improved absorptive capacity of the bile. Maintenance phase, patient is stabilized on their individualized medical nutrition regimen, continued adaptation of the remaining bile. If stabilization does not occur despite optimal medical and nutritional management, intestinal failure will occur. So just treatment, manage fluid and electrolytes, or rehydration and solution, medication for motility, diarrhea, and gastric hypersecretion. Nutrition therapy for short bowel syndrome, assessment of fluid and electrolyte. The nutrition assessment, you want to assess for the fluid and beverage intake. Some nutrition diagnosis may include inadequate energy intake, inadequate protein intake, malnutrition, inadequate vitamin mineral intake, unintentional weight loss, altered GI function, impaired nutrient utilization. So short bowel syndrome nutrition intervention. So parenteral nutrition postoperatively, oral diet introduced as diarrhea decreases, progress slowly to low residue diet and lactose as tolerated. In short bowel syndrome type 3, a low fat, low oxalate diet is recommended. You want to avoid you want to avoid caffeine, alcohol, sugar alcohols, and insoluble fiber. Overgrowth, bacterial overgrowth resulting from cross-contamination of bacteria from the colon to small intestine. The pathophysiology and motility of the GI tract is delayed. Bacteria compete with hosts for nutrients. Clinical manifestation and treatment. The clinical manifestations could be maldigestion, malabsorption, and weight loss. Treatment, broad spectrum of antibiotics. So the nutrition therapy for bacterial overgrowth consistent with the level of malabsorption, malabsorbed nutrients eliminated, increase nutrient density, maximize calorie and protein intake.